Very excited to welcome Nerschel's newest addition to the practice, Dr. Kurt Carlock, coming to us from Northern Virginia, where he did his undergrad at University of Virginia, and then New York University School of Medicine for medical education, and then University of Washington Harborview Medical Center in Seattle for fellowship. We are lucky enough that he calls this area home, so he's back in town and ready to collaborate with TJC. Looking forward to hearing about hip and knee replacement and what's new and why they fail. As a specialist in revisions, certainly I'm sure you've seen it fail a number of ways. So with no further ado, welcome, and the floor is yours.
All right, thank you, Ben. Really appreciate it. Yeah, thanks everyone for taking the time out of your evening to hopefully learn a little bit about hip and knee replacement with me. Ben already gave a nice introduction, but just, as a quick recap, my name's Curtis Carlock. I'm an orthopedic surgeon new to the area. I've kind of traveled across the country over the course of my training, kind of finished my training with an advanced fellowship in complex hip and knee reconstructive surgery, based out of Chicago at Rush University. And I joined the Nerschel Orthopedic Center here in Northern Virginia back in August. Just quickly with the Nerschel Orthopedic Center, we have locations primarily in Arlington on the campus of Virginia Hospital Center, as well as in Tyson's Corner. And all of the surgeons from our group, myself included, go to both of those sites. So that's where I'm out of, and I do most of my operating out of VHC in Arlington, as well as some at Innova Fair Oaks. So moving on into, the meat of today's talk. So quickly, my joint replacement techniques, as a fellowship trained hip and knee reconstruction surgeon, I employ a variety of techniques. I do primarily anterior approach hip replacements. I do both partial and total knee replacements. And then, as Ben alluded to, a fair bit of my practice is dedicated to revision surgery. So right now, around 20 to 25% of my cases are revisions, dealing with failed and infected joint replacements. And we'll kind of have the second half of this talk centered around, why joints fail and how we address that. And then, since it's a hot topic, and we will talk about this, I do for select patients employ robotic and computer navigated surgery, and we'll talk about what that looks like and why I use those techniques when I do. So before we talk about, the what's new and revisions, just really quick, I want to give an overview of what my goals are during hip and knee replacement. And I'm not talking about, making patients better and having less pain, but what about the technical aspects? So hopefully in just a couple minutes, I can give you an overview of what every surgeon's goal is who's doing a hip replacement and when they do a knee replacement, regardless of their specific techniques. So there's a ton of different ways to do a hip replacement, but no matter what, every surgeon is doing hip replacement is trying to accomplish four fundamental goals. That's restore the hip center, restore the leg length, restore the hip offset, and maintain a stable joint. And through what I think is a relatively extreme example, I'll try to show you what each of those four factors entail. So this is an example x-ray of a patient who I took care of last year. This is a patient in their 30s who was born with a relatively profound case of hip dysplasia. The reason you see those screws in there is because they had an osteotomy when they were a child to try to correct their hip dysplasia. Worked well for a number of decades, but now they're coming in and they've got pretty significant hip arthritis. So our first goal is we want to restore the hip center. The hip center refers to the center of the femoral head. That's the point around which any hip rotates. So in this case, you can see the hip center has moved all the way up there when in fact we want it to be quite a bit down lower and more medial. So in the vast majority of patients who develop hip arthritis, the hip center moves cranially and it moves laterally as a consequence of cartilage loss and bone loss in more extreme cases. So we want to bring that hip center back down to the native center of rotation to restore normal mechanics. Along the same lines, we want to restore the leg length. So if I draw a line straight across the pelvis, you can see where on that non-arthritic side, that line hits the lesser trochanter of the femur versus on the arthritic side, it hits quite a bit lower. That shows that that leg has actually become shorter as a consequence of the arthritis going along with that hip center moving north. So we want to bring that leg length back down so that it's close to symmetric to the other side. We also want to restore the hip offset. What the offset refers to is the medial lateral distance between the center of rotation of the femoral head and the femoral shaft. So the distance between those two lines is drawn on the non-arthritic side. So we want to restore that native hip offset on the arthritic side after we do a hip replacement. And all three of those factors are being weighed against the need to maintain a stable joint. So over the course of the case, we're trying to restore the hip center, match the leg length to the other side, restore native hip offset, and we're balancing all those against our desire to make the hip joint stable. So in this patient's scenario, you can see this x-ray after their case. We've successfully accomplished all four of those modalities, while at this time of the operation also taking the hip through a range of motion and ensuring that it's quite stable. Same kind of general idea with knee replacement. There's a dozen ways to do a knee replacement, more than a dozen ways to do a knee replacement. But no matter what, every surgeon who's doing a knee replacement has two fundamental goals. They want to restore a neutral mechanical axis of the limb while weighing that against the need for the knee to be well balanced throughout a range of motion. So once again, I'll use a relatively extreme case to illustrate these 2 points. So what we mean when we say restore a neutral mechanical axis of the limb is the mechanical axis refers to a line drawn between the center of the femoral head and the center of the ankle. A neutral mechanical axis would mean that line hits right in the middle of the knee. So in this example here of a patient with really profound varus arthritis of both of their knees, you can see that line not only misses the knee joint entirely, but even misses the soft tissue envelope of that patient's knee, showing that they have a really significant varus deformity. Their mechanical axis is in quite a bit of varus compared to where we want it to be. So over the course of the case, we want to restore that mechanical axis so that it drops right through the center of the knee at the end. And that scenario is being weighed against the desire for the medial and lateral ligaments to have equal tension on them throughout a full range of motion. Of course, the medial ligaments in a varus knee will become contracted and tight, and the lateral ligaments will become stretched out and lax. And so those ligament tensions, the tension of those ligaments is tried to be made equal on either side of the knee while also trying to restore that neutral mechanical axis. And so this x-ray here is not from that extreme example I showed you. This is in fact that patient's x-ray, but you can see we've restored that mechanical axis towards a more neutral position while also making sure that the patient's ligaments are equally balanced on either side. So that's my very quick overview of what every surgeon, no matter what their specific technique is trying to accomplish when they do a hip replacement and when they do a knee replacement. But the main thing I want to talk about is what's new in joint replacement surgery today, and why joints fail. So, moving into what's new in joint replacement, I think you might be surprised. A lot of what I'll talk about is maybe not necessarily innovations that have been made in the last, 1, 2, 3 years, but rather innovations that we've been making over the course of the last 1 to 2 decades, because we've really made tremendous headway in terms of our patient outcomes, patient pain control, and longevity of these procedures over the last 20 years. And so I'm going to try to talk about all those things. And in terms of the relatively newer advancements that we've made, we'll talk about the pluses and the minuses of them, because as with anything in medicine, there's no free lunch. Some things will come, everything will come with a plus, but there's always a downside that we're balancing when we do those. So the first thing that I want to talk about is direct anterior approach hip replacement. This is a technique that I like to use for the vast majority of my cases, for the reasons that we'll discuss. There are a dozen different ways to approach the hip. You can approach the hip from the front, from the back, from the side, superiorly, anterolaterally, posterolaterally, you name it. Somebody's thought of a way to approach the hip that way, and has, in all likelihood, maybe named it after themselves. I like the anterior approach for a variety of reasons. The anterior approach is the only true intermuscular, internervous approach to the hip that we have today, that involves no muscle releases, no muscle cutting, no muscle splitting to get to the hip joint. We can just move muscle out of the way, and that has a lot of positives that we'll talk about. So the biggest benefit of the anterior approach in a lot of people's mind is the fact that patients have less pain in the early postoperative period when they're managed with an anterior approach. A lot of this is centered around the fact that this is a more minimally invasive approach. We can do it with smaller incisions. We can do it without releasing any muscle. Because those patients have less pain in the early postoperative period, they're able to return to their activities earlier, and they're able to have a faster recovery. And then, in my opinion, the biggest advantage of the anterior approach over other more traditional approaches to the hip is that it has a lower risk of dislocation. And where this is most relevant to you all as physical therapists is that these patients often do not have any hip precautions. Some surgeons may use some relatively conservative hip precautions, but many are employing no hip precautions at all. So why do these patients have such a lower risk of dislocation? We think it all comes back to the fact that there's no muscles being released over the course of this case. So going back to this illustration I showed here earlier, Focusing on this muscle here is one of the muscles of the quad, the rectus femoris. It serves as a muscular sling draped directly over the anterior aspect of the hip. That muscle is not released routinely over the course of an anterior approach hip replacement, and it really is directly anterior in front of the ball and socket joint there. So one of the things that we think is leading to the significantly lower risk of dislocation in patients who are having an anterior approach is we have this big muscular sling directly in front of the hip. A hip that's approached from anteriorly is going to be more prone to dislocate anteriorly, but because we still have that big, strong muscular sling directly draped across the front of the hip, it's lowering that risk of dislocation and making patients have a much safer outcome afterwards. This is as opposed to the posterior approach, where there is no big, strong muscular sling that's retained over the back of the hip afterwards, potentially predisposing to some instability in that direction. In terms of the downsides of the anterior approach, I'd say that the biggest one is that it's not a good approach for all patients, primarily those patients who are more obese. The skin incision does lie directly anteriorly in the region of the hip flexion crease, and especially in patients who do have a large abdominal pannus, it can really lead to well-reported issues with wound healing. So it's a great approach in terms of less pain, but there's a well-described higher risk of patients having issues with wound healing when they're managed with this approach. So in patients who may have a lot of abdominal fat, I may have a conversation with them that it may be better to consider using a more traditional posterior approach to minimize that risk of wound healing problems and then subsequent infection. Additionally, it is a more technically difficult approach, and the aspect of the surgery that is especially more technically difficult is the exposure of the femur. We're working through a much smaller interval. We're working through a much smaller skin incision than is typically used, and it's just more technically difficult to elevate that femur such that we can get access that we need in order to prepare it to accept the femoral component in a hip replacement. Because it's a little bit more difficult to get that exposure, sometimes we can end up trying a little bit too hard to get the exposure that we're aiming for. And there's a well-described higher risk of intraoperative fracture in patients who are managed with an anterior approach. That's especially true surgeons who are early in their career learning this approach. So this learning curve issue we're seeing go away as more surgeons like myself are coming out well trained in the anterior approach. The learning curve issue was more of a problem historically when mid-career surgeons were trying to change the way they were doing hip replacement to do more anterior approach hip replacements. And those fractures that we're getting can sometimes be as small as the one here. You can see this patient had a small intraoperative fracture that's secured with a cable, but sometimes those fractures can be quite a bit larger and can require more accessory incisions to put on plates, screws, cables to repair them. So the anterior approach is more minimally invasive, but because it's more minimally invasive, it's more technically difficult, and that more technical difficulty does lead to a well-described higher risk of fracture. Once surgeons are comfortable with the approach, though, that increase in risk is relatively small. But it is still something I talk about with my patients, every one of my patients who I'm doing an anterior approach hip replacement on. Next thing I want to talk about is partial knee replacement. So partial knee replacement is not something that in and of itself is new, but has gained a lot of traction recently. So I think all of us are probably familiar with the fact that we think of the knee as having three general compartments: the medial compartment, the lateral compartment, and the patellofemoral compartment. Patients who have arthritis isolated to just one of those three compartments, we often consider a candidate for a partial knee replacement. Partial knee replacement has a number of advantages over total knee replacement. The biggest one of those is that it's just in and of itself, it's a smaller surgery. These patients have a quicker recovery. There's less early postoperative pain. They're able to be walking more naturally and get back to the activities like sports more quickly because it is a smaller operation. Patients who have partial knee replacements also are well described to have a knee that feels more natural. There's a well-described patient outcome measure in orthopedics called the forgotten joint score. And the forgotten joint score is just identifying patients who are forgetting that they have had a prosthetic joint replacement put in. And patients who have partial knee replacements have a much higher rate of achieving a desirable forgotten joint score, meaning they feel that their knee is their natural knee, and it's not a knee that's been replaced in the past. We're not sure why that is necessarily. Of course, it's a little bit intuitive that more of the knee is retained to be their natural knee. Perhaps they feel that way. But the leading theory is that the retained ligaments in the knee is the biggest factor. So every total knee replacement that's done, the ACL is sacrificed for the most part. I'm oversimplifying a little bit, but for the most part, every total knee replacement, the ACL is sacrificed. And for the majority of knee replacements done in the United States today, the PCL is sacrificed as well. So those are two of the biggest ligaments in our knee. And the thought is that in partial knee replacement, the ACL and the PCL are retained, and it's probably leading to a more natural kinematics of the knee as the patient uses their knee, and B, it's leading to better proprioception because those ligaments themselves have nerves. And we're sacrificing less of the native nerves of the patient's skeletal anatomy and ligamentous anatomy, thereby leading to a better proprioceptive sense of where the patient's joint is in space, and thus the knee feeling more natural. Also, historically, partial knee replacement was thought of as more of a bridge procedure to total knee replacement, but that line of thinking is beginning to fall out of favor. This manuscript here, published out of the institution where I did my fellowship training, looked at long-term survivorship of partial knee replacements as opposed to total knee replacements, and they have relatively close, near equivalent survivorship, assuming that patients are well indicated. That discussion of assuming patients are well indicated leads into the next part of my discussion of the downsides of partial knee replacement. And that's the biggest downside is that this is not an option for everyone. Partial knee replacement is most successful in patients who have that arthritis isolated to one compartment of the knee, like I was alluding to. Patients who have arthritis in more than one part of the knee are at a high risk of needing to be revised to a total knee replacement in the future. And even patients who are well indicated that at the time of the surgery are not immune to getting arthritis in other parts of the knee. So there is around a 10 to 15% rate of patients being revised at some point within 20 years after the surgery. I do want to just quickly dive into an interesting case study on partial knee indications that's kind of been going around the media a little bit. And that's the discussion of Lindsey Vonn. So you all may be familiar with Lindsey Vonn. She's an Olympic downhill skier, and she became a real big talking point in the orthopedic community because she underwent a partial knee replacement about a year and a half ago now. And she posted all of her x-rays on Instagram, and thus they went around the orthopedic community. So this is a photo taken from Lindsey Vonn's Instagram showing her x-ray. And it's interesting because any orthopedic surgeon who looks at this x-ray looks at that and says that this patient would be a terrible candidate for a partial knee replacement. I know we haven't talked in detail about, x-ray findings in arthritis, but this x-ray, there's a large bone spur coming off of the kneecap here, suggesting advanced arthritis of the patellofemoral joint. There's also large bone spurs coming off of the posterior aspect of the femur, as well as the anterior and posterior aspects of the tibia. I can tell you just from looking at this one view that this patient has advanced arthritis in two, but most likely all three compartments of the knee. But Lindsey Vonn is trying to get back to Olympic level, high level competitive downhill skiing. And Lindsey Vonn sat down with her surgeon and said, my main priority is I want to retain that good proprioception in my knee. I want to have a knee that's going to give me the highest likelihood of being able to get back to sport. And in her case, that's a partial knee replacement. A total knee replacement in all likelihood would serve, somebody like Lindsey Vonn very well, but realistically, you're not going to be doing Olympic level skiing with a total knee replacement in. Those proprioceptive changes are not going to be amenable to doing Olympic level skiing. And then lo and behold, just a few weeks ago, she won her 83rd World Cup race. So clearly this was a good choice for her, but this is an interesting illustration of, this is somebody who had that discussion. I'm sure she knows she is at a near 100% risk of needing to be revised to a total knee replacement at some point, but she had that discussion with her surgeon and made that risk and benefit decision of I want to have that native proprioception and be able to get back to high level sport. So some patients, that's a good option for them. But for the most part, we're not viewing this as a bridge. This is an opportunity to kind of get people back. And most people are not trying to get back to Olympic level skiing. But an interesting study of indications and a good illustration of the pluses and minuses. Next thing I want to talk about is robotics and computer navigation. I'd say this is probably, the most common thing that I get asked about in my clinic when I'm talking about, moving forward with a joint replacement surgery is, do you use robotics or do you use computer navigation? And as I mentioned before, I do use it selectively, and I want to talk about why I use it selectively, when I think it's a good idea, and why I don't use it in all my cases. But I do think that it's a great tool for select cases, and hopefully we can shed some light on when I think that is true. So first off, what is a robotic joint replacement? So in a robotic joint replacement, the patient gets a CT scan first and foremost. That CT scan is then uploaded into a computer, which generates a 3D map of the patient's bony anatomy that we have before the surgery. So going into the operation, the patient has already had an accurate 3D map of their bony anatomy built from a CT scan. Then during the operation, the surgeon secures, some metal arrays to the patient's skeleton that are shown here. Those arrays are anchored into the skeleton using pins. Surgeon does the approach to the knee, and then the surgeon actually maps the patient's bony anatomy with a probe. Because of the arrays that are in the skeleton, as well as an array that's on the probe, the computer is able to get a second set of data to know where the patient's anatomy is in space and know where the patient's knee is. The robot then, combines the data from the CT scan with the data that we get from the intraoperative probing of the patient's skeleton to come up with a really accurate 3D model. And then the surgeon plans the bone cuts based on that accurate model and a measurement of the patient's ligament tension intraoperatively. Once the surgeon plans those bone cuts with the robot, really all that the robot itself is a very precise cutting tool. All the robots that are on the market today involve a saw on a robotic arm, and based on the data that's fed in from the probe and the CT scan for majority of tools, the surgeon plans the operation, and the robot serves as a very precise cutting tool. So the surgeon is still deciding how much bone to remove based on the ligament tension that's there to try to get the knee balanced as they would like to. So that's what a robotic joint replacement is. Fundamentally, it's just a very precise cutting tool, and it's very good at being a very precise cutting tool when it's given good data. So the biggest benefit of robotics and navigation is that it's very useful in patients who may have certain, history or certain conditions that prevent us from using our more typical instrumentation. So the most obvious example of that is patients who have intramedullary hardware. So our typical instrumentation that we use, to cut the femur in a knee replacement goes inside of the femur. Somebody who has a femoral nail in place, as is shown on the left here, that's going to block our standard instrumentation. That patient cannot have a knee replacement done with usual instrumentation. If they can't have it done with usual instrumentation, a robot is a great tool to allow us to do the operation safely and effectively. Same thing if patient has deformity that's going to prevent us from using our standard guides. And then, as I already alluded to, robotics and navigation is very good at doing what it's designed to do in terms of putting implants exactly where the surgeon intends for them to go and making the cuts exactly where they're intended to go, assuming that it's given good data, of course. The biggest downside of robotics and navigation, though, is that despite the fact that it's a very good cutting tool, there's no high-level data to suggest that it results in any superior outcomes to manual techniques. There's been a litany of studies out there looking at robotics and navigation, and here's just some examples looking at long-term outcomes, radiographic outcomes, long-term survivorship following joint replacement, showing no difference between robotics, navigation, and manual techniques. It also doesn't lead to any difference in the proportion of patients who are achieving satisfactory clinical outcomes after the surgery. So outcomes are not changing as a result of using robotics. And then the other downsides are that, as I mentioned, we have to put those arrays into the patient's skeleton. That's going to require either longer incisions or extra incisions to accommodate those arrays. In addition to that, those arrays are held in with pins, and the use of those pins is not without risks. I can say, from my personal experience, while I was doing my advanced training in Chicago, I took care of 2 patients who had robotic knee replacements and fell early postoperatively, and had femoral fractures through the sites of those pinholes. So it's not without risks using those pins. And it's also quite expensive. A hospital has to invest, over $1 million to acquire one of these robotic tools. So my thought process on this is there's cases where it's quite useful. I've only shown a few of those examples where it can be useful. But if it's not necessarily leading to superior outcomes, and there might be some element of risk associated with it, is it something we should be using in every case? I do use it selectively. I think there's cases where it's quite valuable, but I also think there's many cases where it may not offer too much right now. Now, I do think that moving forward, at some point in the future, we will get to a point where robotics is getting us to superior outcomes. And once we get to that point, I think it's important that and I think more surgeons will be using it, and it'll become the standard of care. But right now, in January 2026, there's no high-level data to show that robotics or navigation leads to any better outcomes. And that's my main driver in my decision-making for what I'm using. Next, we'll wrap up here with kind of a few little rapid fire things that have made big improvements in joint replacement. First is perioperative pain protocols. Out of everything I've talked about, I think this is probably the single biggest advancement that we've made in joint replacement. Back in the 1990s, the average length of stay after a knee replacement, average length of stay was 6 days. Now, we're around 1 day, and many patients are going home the same day. And that is, yes, we have made some advancements in our surgical techniques, but I'd say I would argue that even more so than our surgical technique advancements is our perioperative pain protocols. I won't bore you with the specifics of the medications that we're using, but just my typical perioperative course and the typical perioperative course for many surgeons who do hip and knee replacement is patients are going home the same day in many cases. I advise them that a lot of the medications they get during the operation are going to wear off after around 2 or 3 days. So I warn patients the pain is going to be worse around 48 to 72 hours after surgery. All patients starting therapy immediately post-op. And my general rule of thumb that I tell patients is that I expect them to be about 90% recovered in 90 days, with the full recovery taking around a year. And then my last point that I want to mention in terms of big advancements in joint replacement is improved implant durability. This is something that's coming up on 20 years old now, but before the early 2000s, there was a myth that went around, or sorry, before the early 2000s, there was a general rule of thumb that joint replacements only last 10 years. So now that myth still floats around, and there's still a lot of patients who are saying that joint replacements only last 10 years, or they'll be told that things only last 10 years, so it's better to put things off as long as possible. When we look at the data, 20 years after surgery now, 90% of total knees are still functioning well, 80% of total hips are still functioning well and haven't had any issues. And the caveat with that data is that we only have 20-year survivorship data for surgery that was done 20 years ago. And in all likelihood, surgeries that are being done now, those numbers are much better. Of course, I can't predict the future, but I'd expect both of these numbers to be well north of 90% now, especially that hip data. 20 years ago, things like metal-on-metal hip replacements were still being done that really cloud that data. But now with the advancements we've made, especially in the manufacturing of these components, the polyethylene liners, the implants are lasting much longer, and we're hardly seeing any element of wear on them. The big change that was made is we discovered if we blast this plastic with high dose radiation during the manufacturing process, the plastic cross-links to other strands of plastic and becomes much more durable. And that advancement alone in manufacturing has made the polyethylene liners last substantially longer. And for most patients, it's a one and done operation. And for those who it does wear out, it's usually isolated to patients who have significant obesity or are really using their joint replacement heavily, doing things like high impact sports and running. So next, I want to move into the discussion of the failed joint replacement, and that's a special area of interest for me, and I deal with these patients a fair amount. And I hope I can shed some light on the thought process that I bring when I'm dealing with a patient who has persistent pain following a joint replacement, and shed some light on some of the surgical tools that I use when I'm doing revision joint replacement surgery. I will leave a little preamble to this part of saying you could attend a several-day seminar on revision joint replacement surgery, and so we're just going to be brushing the surface, and hopefully I can give you some idea of the thought process that I bring to working these patients up and managing them surgically. So in general, joint replacements are excellent, but they're not perfect. Especially true for total hip replacements. There was an article published in the Lancet in in the early 2000s that referred to hip replacements as the surgery of the century, of the 20th century, because of how well they do, their relatively low complication rate, and their effectiveness in alleviating arthritis pain and arthritis stiffness. And total knee replacements, are also quite effective, not quite as effective as a total hip replacement, but about 90% of patients are very pleased with their operation after a total knee replacement. So a lot of people view these numbers as a huge success. As a revision surgeon, I view them as room for significant improvement. So I look at those hip replacement numbers and I say, well, we still have 2 to 5% of patients that aren't satisfied. And I look at knee replacement numbers and I say we still have 10% of patients who aren't satisfied. That's a problem. We need to address that. What's the biggest predictor for a patient being dissatisfied? It's unrealistic patient expectations or poor patient counseling before the operation. So before we even talk about revision surgery and why joint replacements fail, the biggest reason why patients are dissatisfied is they didn't have a good expectation of what things were going to look like after surgery and what their knee was going to feel like. We've all dealt with knee replacement patients. Knee replacements universally do not feel like a native knee. A lot of patients go into a knee replacement expecting it to feel like the knee they had when they were 18 years old. That's just not realistic. If a patient is going in expecting to have a knee that feels exactly like the knee that they had when they were a teenager, they're going to be dissatisfied. And realistically, it's those patients who are the biggest proportion of patients that are dissatisfied after joint replacement surgery. So to improve joint replacement outcomes, the most important aspect is appropriate preoperative counseling and doing surgery in patients who are well indicated for the operation and have advanced arthritis. So poor counseling and doing surgery on patients with not advanced arthritis is a recipe to have a dissatisfied patient. In terms of patients who have failures, there's a litany of reasons for why joint replacements can fail. But when we're referring to knee replacements, at least, the three biggest contributors to a failed joint is number one, infection, number two, loosening of components, and number three, a mechanical complication, meaning either instability, ligament irritation, dislocation, problems with the implants. There's a variety of factors that can fall under that. And then there's a number of possible etiologies of failure that didn't make it on this list here, but there's a lot of reasons why joint replacements can fail. When we're looking at hip replacements, the reasons that they fail are a little bit different. The number one reason why total hip replacements fail and why patients undergo revision surgery continues to be dislocation. Around a quarter of all patients who undergo revision for a hip replacement is because their hip is dislocating. And so that really gets into the, why I think that the single biggest benefit of anterior approach hip replacement is the lowest dislocation risk. It's because dislocation continues to be the number one reason why patients are having revision surgery for hip replacement today. So trying to find ways we can reduce the risk of dislocation is going to be the single biggest thing we can do to drive down the revision rate after hip replacement surgery. Other causes of hip replacements failing include loosening of the components, infection once again is up there, and implant failure. And I'll show you a few illustrations of what some of these factors refer to. Next, I want to just quickly talk about principles of revision surgery. So number one, only operate on a patient who has a painful joint if there's an identified problem to fix. Like I was alluding to earlier, there are a number of patients who are dissatisfied with their joint replacements, but who do not have an underlying mechanical problem. One thing that we know and we've established very well through well-powered studies is that revision surgery for a non-identified mechanical problem or a non-identified source of persistent pain or failure is a recipe for a patient to have a bad outcome after a revision surgery. So you want to be doing a revision surgery because a patient has one of the problems on this list or the extended list of why patients undergo revision. If you just do a revision surgery because a patient has a knee that still hurts after a knee replacement, that is a recipe to have a patient who has a bad outcome after a revision surgery. You want to be going in to revise instability. You want to be going in to revise an infection or a failure, a mechanical failure with the implant. Those are the patients who are going to do well after revision surgery. And then we only want to revise the parts of the joint replacement that need fixing. Every knee replacement has a femoral component, a tibial component, a patellar component, and a polyethylene liner. If only one of those parts has a problem, we only want to fix the one part. If the whole thing has a problem, we'll fix the whole thing. So revise only the parts that need fixing to minimize the morbidity of such an operation. We need to obtain adequate exposure. I'll show you some examples of why that can be difficult, but revision surgery, oftentimes the whole meat of the operation is getting out the component that was in there before. So obtaining adequate exposure to remove components is more than half of the surgery in and of itself, and then the reconstruction comes after that. Removing components often leads to substantial bone loss. So when we do revision surgery, we need to ensure that our revision components have good fixation into the bone. So I want to show you some of these principles through a series of case examples of revisions that I've done in my practice and over the course of my training. So this is a patient who comes in, and we'll start with some more straightforward ones and then move into some more complicated ones. So this is a patient who comes in a few years after a knee replacement, and they have excruciating medial and anterior knee pain. If you put their knee into some valgus stress, the patient's jumping off of the table. When I look at this X-ray, they have an obvious mechanical problem. This tibial base plate was left quite proud medially here, and that tibial base plate is irritating the MCL. Every time that patient has any pressure that's put on their MCL, they experience excruciating pain. And then on top of that, if we look at this patellofemoral view, something has gone awry with this kneecap is not tracking centrally in the trochlear groove there. So it turned out, from further workup that this femoral component was a little bit mal-rotated. So this patient goes to the operating room. They have a problem with the tibia. They also have a problem with the femur because it's mal-rotated. So we revised both the components. In the act of removing those components, we compromise some of the bone stock. So because it's a revision surgery, we have to add stems that go up the femur and down the tibia to make things more secure. This is also a highly porous metal cone that further secures the tibial component in. And afterwards, you can see that source of irritation of the MCL is gone. That patient's kneecap is tracking much more centrally. This patient is very happy with the outcome of their operation. So we went in, we had a plan, we knew what we were going to fix, we correctly addressed the problems, we effectively addressed those problems. Patient is very happy with the outcome of their revision surgery. Here's an example of a hip revision patient. On the left side here, we can see their original X-ray. Hip replacements functioning very well. They have a fall, and then they continue to have some lingering hip pain afterwards. It's somewhat subtle, but you can see that the position of this acetabular component, the cup, has changed after the fall. So this hip replacement's come loose. This served the patient well. This was actually, almost 30 years old. Then they fell, and the hip replacement came loose, for some reason from that trauma. We've identified the problem is that the implant has come loose. So we do a revision. The femoral component is still very strong, so we leave that femoral component in place. We do an isolated revision of the cup, the acetabular component. We put a new cup in there because the bone stock is compromised from needing to remove that old one and the old cup coming loose. It's secured with a high number of screws. This patient's very happy with the outcome of their hip replacement. And then, we talked about how component removal is key. Here's an example of a patient who, unfortunately had a hip replacement done in the early 2010s. The metal alloy that was used to produce this hip replacement was found to be defective. And develop corrosion over time and fails. This is a described failure mechanism for this, where the metal itself is weak and fails. So they come in and they have a failed hip replacement. The prosthesis itself has actually fractured and failed. The socket looks fine, but the femur is a problem. One thing just from knowing implants, this implant is very difficult to remove. It's fully coated the whole way down with an ingrowth surface. This is very, very difficult to get out from the top. So as a revision surgeon, we know our tools that we have available to us. When we have a difficult femoral component to remove, sometimes we have to do a surgical osteotomy or surgically fracture the bone to be able to remove it. So in this operation, we surgically fracture the femur bone in order to get that femoral component out and be able to revise it. And here's that patient's X-ray afterwards. You can see the signs of that, surgical fracture, that surgical osteotomy used to access that femoral component. We remove it, and then we place a new femoral component in there that bypasses that fracture and serves the patient quite well while retaining their acetabular component that they had previously. In addition, it's very important to remember that any patient who's undergoing a revision is going to have a very thorough workup. It's very easy to get tunnel vision and focus on the obvious problem. This is a patient I took care of who comes in. They came in with, sudden onset, significant pain in the left hip, and it's obvious that something has gone wrong here. The femoral component has become disconnected from the femoral head. The ball is sitting in the socket, but the femur is no longer attached to that ball. Something is wrong. It'd be easy to get tunnel vision and focus on that. But we do a workup and we find out that not only does this patient have this mechanical problem, they also have an infection. So sometimes there can be multiple underlying problems. This patient has an infection. We have to manage it appropriately. The way we manage infected joint replacements is by removing all the components from the prior one and then putting in antibiotic component implants to treat the infection for a number of months, and then removing those antibiotic coated components and putting in a final hip replacement. So just the example from this patient, they had two problems. They had an infection, and then the femoral head had actually fractured in half, and the femur had come disconnected from the head. So a pretty unique scenario, but good thing we worked him up fully, because if we'd had tunnel vision and just focused on the fact that the femur had come disconnected from the head, we would have missed the fact that the patient had an infection. But the good news is we got him treated with both. And here's an example of an antibiotic coated implant. You can see this cloudy appearance around the joint replacement. That's antibiotic filled cement that's going to elute out and treat the underlying infection. And then, lastly, it's important to know that, in 2026, we have a lot of really advanced tools available to help us with complex cases. This is a patient who's had, multiple revisions of their hip replacement in the past, and now their acetabular component has started to migrate through the bones of their pelvis because they're losing so much pelvic bone. We get a CT scan. We can use that to reconstruct the anatomy of the patient's remaining bone. And with this, this is not something that we can reconstruct with standard components. So we have the ability to, make custom 3D printed porous metal components that we can use to basically reconstruct an entire hemipelvis at this point. So this patient had it's called a custom tri-flange 3D printed component that's secured to their skeleton, and we map all this out based on the preoperative CT scan to reconstruct the patient's hemipelvis. And after the operation, it kind of just looks like a big glob of metal in there, but now they've got a highly functional hip socket that serves them well. In terms of recovery following revision surgery, as you're probably beginning to pick up on, there are a ton of different causes of revision surgery, and there's a lot of different ways that these cases need to be approached. The recovery is going to be highly variable. Some patients are going to have a recovery that mimics a primary joint replacement. Other patients are going to have prolonged hospitalization, limited weight bearing, and it'll be very important for if you all are ever working with revision joint replacement patients, taking careful note of, making sure that the surgeon has communicated if there's any relevant restrictions. Along those lines, many surgeons avoid therapy following hip revisions due to concerns for instability. And that's something that's a little bit of a controversial trend. I think for a lot of revision hip replacement patients, surgeons are just approaching it with the idea of all we want to do is minimize the patient having a risk of any dislocation. And if there's any chance that doing any stretching could lead to that, even 3, 4, 5 months down the road, maybe we should avoid it. So that's something that's kind of case by case for me. Usually I'm using physical therapy for all my primary and revision patients, but I will selectively avoid it if it's a scenario where I want to be extra certain that there's no possibility that that patient gets put into a position that could predispose to a dislocation. So in summary, for revision surgery, hip and knee replacements can fail for a variety of reasons. Every surgery is unique, and so is the recovery. As I showed through these cases, the underlying problem needs to be identified and addressed accordingly. And it's imperative that surgeons are planning extensively before the actual operation so that we have the right plan, we're fixing the right problem, we have everything available to us. That's all that I had prepared. I'd be happy to answer any questions that anyone might have about this. Here's my contact information, so please feel free to reach out to me directly. That's my cell phone there, and that bottom email is my personal email address. I'm just getting ramped up now, so I'd be happy to have anybody come in and shadow. Realistically, probably give me a little time just to get a little bit busier so we can have some good educational cases to run through. But after a couple months when my schedule is a little more routinely full, I'd be happy to have anybody come in and shadow and do some learning and do some education. So please don't hesitate to reach out. But if anybody has any questions, I'd be happy to answer them.
Excellent. Thank you so much. That was very, very informative. First question is more logistics, and then we'll, as people throw in questions in the chat, we'll start addressing those as well. So suppose one of our team members identifies that they have a patient who might benefit from either a primary surgery or revision surgery. What would the best approach be to get in contact with you? Should we go straight to your cells? Should we be shooting you an email? How should that work?
Honestly, I'm accessible either way. I probably respond most reliably to my email, but if you want to shoot me a text, I'll get back to you as soon as I can. And that might be the easiest for a lot of your workflow, and I'm happy to respond to a text message. So please feel free to reach out, whatever's most convenient. I'm happy to be reached at my cell or via email.
Perfect. And then second question is, with 85 different PTs in our practice, the question is, if you could wave a magic wand and have exactly the type of caseload that you wanted, what would that be? Just that obviously they'll send you the people that they think are appropriate, but if you got to pick, what would your favorite cases be?
So, I mean, I love taking care of patients with hip and knee arthritis who need primary joint replacements, and I love taking care of patients who have, pain after joint replacements. Realistically, I think, in terms of my ideal breakdown, Fortunately, there's not a ton of patients out there who have, indications for revisions. So I think ideally, I'd like to keep somewhere around 80% primary joint replacement, 20% revision joint replacement. But, I'm happy to see any patients with persistent pain after a joint replacement, or if you have any concerns about their function after a joint replacement, happy to see them. And then any patients with hip and knee arthritis, even if it's early in their treatment pathway, I'm happy to see them, get them looped in. I know a lot of joint replacement surgeons like to only see, arthritis patients once they're ready for surgery. I kind of think of myself as a full spectrum arthritis doctor. So even if a patient's coming in and they never seen an orthopedist, to talk about their knee, I'm happy to see them, get them started on that pathway with things like steroid injections, medications, and counsel them through that. So really happy to see anyone on the spectrum of arthritis treatment and anyone who's had a joint replacement in the past.
Excellent. Thank you. So we've had a couple questions come through the chat and one hand up. So the first question that came through was, why can't you leave in the antibiotic coated implant for the long term?
So sometimes we do. That's a great question. Sometimes we do. The reality is the antibiotic coated implants are usually not the most secure. They're held in with antibiotic cement, but the problem is when you load bone cement up with antibiotics, it becomes less grippy, for lack of a better word, to the bone, and it doesn't secure the implant nearly as well to the bone as if it doesn't have antibiotics mixed in. If we left them in all likelihood, they would come loose. Some surgeons do leave them in until they come loose. Other surgeons plan to remove them at a predetermined time afterwards to avoid the complications that can arise from a loosening antibiotic-coated prosthesis. So a little bit of it is surgeon dependent, but if they are left in, they will come loose. That is a certainty, and so it's just a matter of how long you want to wait.
Got it. And then AB, feel free to unmute and ask your question, and then we'll jump to the other question in the chat.
I think JVK asked the question first, so I think you can take that one and then I can chime in.
Okay, great. So the second question in the chat was, since about 10% of patients status post TKA are not satisfied with the outcome and complain the knee does not feel right, do you do or have an opinion on cruciate sparing TKA where ACL and PCL assist in preserving medial pivot mechanics of the knee?
So great question. Bicruciate retaining total knee replacements gained a lot of traction in the early and mid 2010s, and I think it's a great philosophy for a lot of the reasons that we talked about. Unfortunately, the data just panned out as they don't do as well as our more traditional designs. So that's why a lot of surgeons have moved away from that. That is by no means saying that they're the wrong option. Some surgeons do get good outcomes from them, but in our wider studies, we found that patients do better in a more general sense in more traditional type designs, especially as we've moved to more medial pivot, more medial congruent type polyethylene liner designs that are able to replicate more native knee biomechanics without needing to retain the ligaments. So for example, when I do my nodal knee replacements, I use a medial congruent design polyethylene liner that sacrifices both the ACL and the PCL. And we're seeing very good biomechanics data and very good proprioceptive data afterwards with that. And we're still working. So that's an area of future research of how we can best reproduce native knee biomechanics and lower that 10%. But bicruciate retaining total knees, I should say, the data did not pan out as we were hoping.
AB? You're muted, sorry.
Oh, okay. Now, can you hear me? All right, cool. Thanks for giving the talk, Doc. As I said, I would be there to curl my glasses too. Got a couple of questions. The first is how important it is, you go into these joints and you do all of those complicated stuff. So are you giving out op reports to your patients to take to their PTs along with your rehab protocol? And the second is go ahead.
So just to answer that, I don't routinely supply my op reports. I try to, if there are any precautions, have those well laid out in the PT order so that there's specifics there. But I'm not usually supplying my op reports. If you think that's something that would be helpful, it's honestly not something I've considered before. So if that's something that would be helpful, please let me know.
Yeah, I think this is one of our pet peeves that most of our surgeons that are referring to us, we always ask for this. And we also encourage our residents to ask for that so that at least they understand the complexity that you had to work with in order to fix this, and that we understand what we are walking into to make this a successful outcome.
Great. Thank you for the information. Yeah, I will start doing that.
Yeah. The second one is like the robotics part of it. Like it's catching now, and like most of the surgeons are on board, but a lot of them also have a component which is out of pocket because the insurance is not covering for the cost. Do you have the same problem for knees and hips also?
Just to make sure I understand the question, like, is my practice charge an additional fee for the robot? Is that?
So let me give you the specific example. So a lot of shoulder surgeons, they looked at the data that if the patient is less than 5 feet and 3 inches tall, they only have a few spots to put their implants in the scapular region. So they
Mm-hmm.
would do that 3D analysis, and I think they do it on their own time, but they are recalibrating like exactly what spot they need to put the replacement part in. But that is done like it's a simulation that they're running on a program, and that costs a lot of money, and the insurance is not covering for that part. So is that something that you also have to like struggle with?
Not so no. If I understand the question correctly, no, there is no additional, I guess, pre-operative planning that insurance is not covering. Um, there are some insurances that will not reimburse for the CT scan preoperatively, for example. And so that is a point where it comes up to the patient if that's something that they want to be using out of pocket. I think a lot of that realistically comes down to the fact that there's no data that shows that these tools are making patients any better. So why would an insurance company pay for a CT scan? I think that as we get more data that these tools are helpful, that will become less of a problem. Realistically, if you have a patient who needs a robotic joint replacement, like if you have a case with a patient who has an intramedullary implant and they need a robotic joint replacement, they can't have a traditional one. In that case, insurance companies will almost always, pay for it. You just have to describe why there is a medical necessity for the technology in that case, and it's something that I've not seen be an issue in the past. So, in situations where it is a necessity and is going to offer concrete benefit, we don't run into those kind of issues with approval and getting the extra tests that are needed. But yes, it does require some extra expense in terms of the robot and the scan. But that has not been a large problem in today's environment.
All right. Next question in the chat was, would we typically expect a 65-year-old male to be on opioid pain medication 3 weeks after a total knee, assuming that person was relatively non-comorbid and was active previously?
So would we expect it? I'd say no. I'd say the average patient is not still on opiates at around 3 weeks after surgery. But it sounds cliche, but every patient responds to pain differently, and every surgery is different, and every patient metabolizes pain medications differently. So by no means is using opiates 3 weeks after surgery a cause for concern for me. When I see my patient back at their 2 week post-op, if they are still using narcotics, I'll see if there's a concerning reason why. Is there an identified mechanical problem? Is there a wound issue? And if there's not, I don't think that falls outside of the realm of normal. I'd say that is a greater degree of pain than the average patient after surgery, but does not fall into a realm that concerns me. I hope that's helpful.
Awesome. Next question. With the anterior approach, what's your complication rate for injury to the lateral femoral cutaneous nerve? Or is there another explanation for patients' complaints of anterior lateral thigh sensitivity or pain post total hip?
So there's not another explanation. No, that is the cause. So there's a well-described risk, depending on the study that you look at for LFCN injury after direct anterior approach hip replacement, the rate of at least temporary or transient neuropraxia is somewhere between 50 to 80%. So, more than half of patients are going to be having some element of transient neuropraxia of the LFCN. In terms of how long that lasts, that's highly variable. I don't know the number off the top of my head for permanent numbness in that area, but I do know it's in the single digits for permanent numbness in the distribution of the LFCN. Well-described risk, something we counsel all of our patients about. The good news is for the majority of folks, that's not a functional problem. Some patients do get pain in that distribution, like a CRPS type syndrome. But fortunately, for the majority of patients who do have even permanent numbness in that area, it is no more than an annoyance, and it doesn't offer any functional deficit. In terms of ways to avoid it, there are some surgical tricks that we've refined over over the decades since this has been since this has gained more traction. And a lot of it is just about incision placement. I intentionally put my incision more laterally than surgeons who I was training with 5 years ago. And that's because, we've learned we can do these surgeries safely and effectively with a more lateral incision, protect that nerve a little bit, and reduce the incidence of it being, cut. And instead, it's more of a transient issue from just pressure from the retractors that are used during surgery.
Fantastic. And last question, have you heard of anyone doing dry needling while the patient is under anesthesia right before the replacement?
That's not something I've heard of. I'm not sure I would see much benefit in that, and I would be concerned about the small, extremely small, but theoretical risk of that potentially leading to an infection problem. So that's not something that I would consider in my practice, but it's an interesting idea.
Absolutely fantastic talk. It was a true pleasure. Welcome to the area. Excited to have you to collaborate with. I will be blasting this out to everyone in our group so that they'll have all that information and know how to contact you, and certainly reciprocate on your end. If there's any contact information you need for local PTs or clinic directors, I'm happy to provide that to you as well. Thanks again
Yeah,
for your
I
time.
would love
Thank you
that.
all for attending, and to all who are listening to the recording.
Thank you so much, everybody.